Submucous Fibrosis, OSMF. Quick Learning with Simplest Notes. By ClassicDental. Content. Introduction. Etiology. Clinical feature. Histological feature. Management. Introduction. This condition was described first by Schwartz, a descriptive term atrophia idiopathica, tropica, mucosioris. It is a chronic and high-risk precancerous condition. Definition. An insidious, chronic disease affecting any part of the oral cavity and sometimes pharynx. Although occasionally preceded by and/or associated with vesicle formation, it is always associated with juxtaepithelial inflammatory reaction followed by fibroelastic changes of lamina propria, with epithelial atrophy leading to stiffness of oral mucosa and causing trismus and inability to eat. Etiopathogenesis of OSMF. Chewing areca nut may be an important factor in the etiology of OSMF. Contributing etiological factors are as chilies, tobacco, lime, betel nut, nutritional deficiency, bacterial infection, collagen disorders, immunological disorders, genetic susceptibility. Pathogenesis caused by betel nut. Metabolism of areca nut-specific nitrosamine, formation of areca nut-specific nitrosamine, tannic acid and arecaline content. Clinical features. Age and sex distribution. Both sexes affected. Majority of patients aged between 20 and 40 years. Site distribution. Most common locations: buccal mucosa, retromolar areas. Also involves soft palate, palatal fauces, uvula, tongue, labial mucosa. Possible involvement: floor of mouth, gingiva. Prodromal symptoms: insidious onset, lasting 2 to 5 years. Burning sensation of oral mucosa, aggravated by spicy food. Initial symptoms followed by hypersalivation or dryness of mouth. Vesiculation, pigmentation, recurrent stomatitis, and gustatory sensation issues noted. Blanching of mucosa, early sign, blanching due to impaired vascularity. Mucosa turns opaque and white. Blanching may be localized, diffuse, or reticular. Gives the mucosa a marble-like or lace-like appearance. Late symptoms of OSMF. Trismus, gradual stiffening of oral mucosa, leading to limited mouth opening. Difficulty in tongue protrusion. Difficulty in swallowing as fibrosis extends to pharynx and esophagus. Referred pain in ears, deafness, nasal voice due to eustachian tube occlusion. Fibrous band, progression results in stiff mucosa and vertical fibrous bands. Bands palpable and rough on touch. Buccal mucosa. Affected mucosa becomes coarse, blanched, and inelastic. Advanced cases: tough, leathery, multiple vertical fibrous bands. Soft palate and uvula, soft palate involvement marked by fibrotic changes. Restricted soft palate mobility. Uvula shrinks. Extreme cases resemble bud or hockey stick. Tongue, depapillation. Tongue becomes smooth. Its mobility, especially in protrusion, becomes impaired. Associated features. Pigmentation changes common. Hyperpigmentation or loss. Vesicles, painful, occur in red areas. Rupture into superficial ulcers. Ulceration in advanced cases due to fragile epithelium. Petechiae, small raised reddish-blue spots, transient, often on tongue and mucosa. Clinical stages of oral submucous fibrosis. Histologic feature. Early stage. In this stage, juxtaepithelial area shows early hyalinization. Collagen, seen as separate bundle, thickened. Young fibroblasts, moderate numbers. The blood vessels, dilated and congested. Moderately advanced stage. The collagen is moderately hyalinized. The amorphous change starts from the juxtaepithelial basement membrane. The adult fibroblastic cells have elongated spindle-shaped nuclei and scanty cytoplasm. Blood vessels are either normal or constricted as a result of increased surrounding tissue. Advanced stage, the collagen is completely hyalinized and is seen as a smooth sheet with no distinct bundles or edema. Hyalinized connective tissue becomes hypocellular with thin elongated cells. Blood vessels are completely obliterated or narrowed. The inflammatory exudate consists of lymphocytes and plasma cells and occasionally eosinophils. Interestingly, the melanin-containing cells surrounded by dense collagen, which explains the clinically observed loss of pigmentation. Management. The reduction or even quitting of the habit of areca nut chewing is an important preventive measure. Nutritional support: high proteins and calories, vitamin B complex and vitamins, minerals. Immunomodulatory drugs, local and systemic applications of glucocorticoids and placental extracts are commonly used. Physiotherapy, forceful mouth opening and heat therapy. Heat has been commonly used and the results have been described as satisfactory. Local drug delivery: local injections of corticosteroids and placental extract have been tried, in addition to hyaluronidase. Combined therapy: the combination of peripheral vasodilators, nilidrin hydrochloride, vitamins D, E, and B complex, iodine, placental extract, local and systemic corticosteroids, and physiotherapy claim high success rate in OSF management. Surgical management: submucosal resection of fibrotic bands and replacement with a partial thickness skin or mucosal graft has also been attempted along with procedures such as bilateral temporalis myotomy. At a retrospective glance, surgery seems to be a poor option in the overall management of the disease. References: Schaeffer's Textbook of Oral Pathology 9th edition, Oral Medicine and Ilg Home 2nd edition. Yeah.